Pamela Weiss. I'm a pediatric rheumatologist from Children's Hospital of Philadelphia and the Perelman School of Medicine at the University of Pennsylvania. I am also lucky enough to be a board member of the Spondylitis Association of America's Medical and Scientific Board. I'm going to talk to you for the next couple of minutes about pain, which can complicate the management of spondyloarthritis in children. So just as a review, and many of you probably already know this without me having to tell you, pain is defined as an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage or is described in terms of such damage. Chronic pain is pain that is either recurrent or persistent and can affect anywhere in the body, including the bones, joints, muscles, or soft tissues. And typically, chronic pain is defined as something that lasts longer than normal tissue healing time, which is expected to be 3 to 6 months. So in children, we often use the term amplified musculoskeletal pain syndrome, or AMPS for short. It's important to recognize this is an umbrella term. This term does not assume an etiology. And we see AMPS both in healthy children without underlying medical conditions, as well as in kids with underlying issues like spondyloarthritis. Sometimes AMPS is part of the initial presentation, and sometimes AMPS develops after diagnosis. But what is basically happening is the body is amplifying the pain response. Your child is not willfully exaggerating the pain. So in terms of terminology, like I said, amplified musculoskeletal pain syndrome is what we could call an umbrella term. And there are numerous different names for this. If you Google it or talk to different people, you're going to hear people use all different terms, including neuropathic pain, fibromyalgia, juvenile fibromyalgia syndrome, chronic widespread pain, complex regional pain syndrome, chronic fatigue syndrome. And we're all basically talking about the same thing. We're just using different terminology. So I think this is really important to recognize up front. We don't really know what causes pain, but we know there are lots of things that contribute to the onset of pain. And these include multifaceted type things such as listed here. So social environmental factors can contribute, including school, family relationships, stressors at home, peer relationships, individual history, including significantly stressful events, admissions to the hospital, recent illnesses, injuries, fractures. Biologic factors also play a key. Maybe there's a history of pain in the family. Maybe there's a sedentary lifestyle, and then also psychological factors we know also play a part in this too. Common symptoms that we see along with the pain itself are that the pain has been there for a very, very long period of time. Oftentimes, when this is finally recognized, the children have been through multiple different kinds of treatments, including medicines, physical therapy, stimulators, and really nothing helps improve the pain. These children also sometimes tend to be extraordinarily tender. So they have pain to different types of stimuli that they know and you know really shouldn't cause pain. So sometimes these kids have pain with hugging, just rubbing your fingers along the surface of their skin or even putting on clothes. And when you ask the children to rate how uncomfortable they are on a scale of 1 to 10, sometimes they'll say 10 out of 10, and sometimes they'll even go beyond the scale and they'll say, I am 100 out of 10, that's how uncomfortable I am. So what kinds of things help doctors distinguish AMPS from inflammatory arthritis? So with inflammatory arthritis, we typically see morning stiffness. This means the kids feel like 90-year-old people when they get out of bed in the morning. With AMPS, they typically do not experience stiffness. Children with inflammatory disease or inflammatory arthritis typically have some sort of relief with over-the-counter medications like Tylenol, ibuprofen, Aleve. With AMPS, the pain is untouched with these medicines. In particular with spondyloarthritis, many of these kids will complain about back pain. In inflammatory back pain, with activity, the pain usually gets better. With AMPS, activity usually makes it much worse. With inflammatory joint disease, we often see swelling with AMPs, not as much. And with inflammatory arthritis, with movement, and as they get throughout the day, the kids usually feel much better towards the end of the day than they do when they wake up. With AMPs, they typically feel bad all day long. Children with inflammatory disease usually do not have exquisite sensitivity to light touch or gentle pinch, whereas many but not all of the children with AMPs do. So what kind of investigative studies might be done to help guide your doctors in terms of making this assertion? So blood work that we typically do on children with arthritis tends to be normal. Radiographs or x-rays tend to be normal, or sometimes they show osteoporosis or thinning of the bone because your child's in so much pain they're not using that extremity as much as they should. Bone scans are not typically done, but if they are done, they're either normal or sometimes they show some spotty soft tissue and bone inflammation, and that's because of altered mechanics as well as altered blood flow. And then similarly, if an MRI is done, usually the findings are either normal or there may be very mild or spotty soft tissue and bone inflammation, again from altered mechanics and or altered blood flow. So what are some of the very real physical exam findings we see in these children? So over here you can see with altered blood flow, we can get some leaky vessels, and the affected foot over here, the left foot actually looks pretty swollen in comparison to the right. And you can also see some discoloration here, some purplish bluish discoloration, which is much more apparent in this young child who has what we call a cold blue foot. And again, over here, you're seeing both swelling extending up to the knee as well as the foot and some discoloration here. Oftentimes, we can also hear about temperature changes. So children will say the affected area, when it hurts, it's cold. And again, many of these children, when you just rub your hand over the surface of the skin, will have exquisite pain. So what other symptoms are common along with this exquisite pain? Many of these children have headaches and are very sensitive to sound and light. Many of them have abdominal pain, and this can include irritable bowel syndrome, something called abdominal migraines, which are recurrent abdominal pain. And they can also have what's called functional abdominal pain. They can also have autonomic dysfunction, which is often clinically referred to as, in some children is referred to as POTS, so that when they stand up, they get really dizzy. So we see sometimes a lot of that in these children, and many of them have trouble sleeping, both falling asleep, they have difficulty, as well as multiple nighttime awakenings. So psychological issues that can also arise in these children are that they can also often have either underlying anxiety or depression, or the anxiety and depression can develop as a consequence of the long-standing pain. Some of these children will develop disordered eating, and there can also be evidence of self-injury and suicidality. So while I do not mandate counseling in children that I give this diagnosis to, I strongly urge families to consider it, as it can be a very integral part of the treatment and recovery of these children. So the basic treatment approach for children that we think have AMPs, and again, this is irregardless of if it's in a healthy individual or if it's in a child who has spondyloarthritis, is primarily non-pharmacologic, meaning adding additional medications or changing medications or underlying medications that are being used for their spondyloarthritis are unlikely to affect this pain. It's a multidisciplinary approach, again, which includes things like physical therapy, occupational therapy, your rheumatologist, and counselors. The main emphasis is on restoring function. And with our treatments, you may see your child return to normal function before the pain completely goes away. But over time, the emphasis is on both return to function as well as reduction of pain. Our general approach, at least at CHOP, may be counterintuitive to the typical approach to pain. So oftentimes I'll explain to parents with normal physical therapy, the therapist will move the children around, and as soon as they say ouch, they'll stop. With this kind of therapy, we actually figure out what triggers the pain, and then we work them through the pain, because we want to retrain their nerves to remember what normal sensation is. We often warn the families that the pain may get worse before it gets better, but if the child knows that they are not going to hurt themselves by participating in the things they really want to do, this is ultimately going to help them get better. So the ABCs of treatment are aerobic exercise, including PT and OT, behavioral health referral, including counseling, curbing over-medicalization and discontinuing medication. So these children are very stressed out, they're uncomfortable. The last thing they need are additional blood tests and imaging and lots of different medications piled on top of them. At the stage AMPS is usually diagnosed, at that point in treatment, we just want to start making the children better and not subject them to additional interventions. We use desensitization techniques specifically, again, to try and retrain the nerves to remember what normal sensation is. And education is key. There is an ever-growing resource, including little tidbits like this that are going to help you to understand exactly what AMPS is. And that is your brief introduction to AMPS, which can complicate the treatment and approach to juvenile spondyloarthritis. Thank you for joining.